We're going to move to the next abstract, left subclavian artery revascularization during the debranching procedure for acute type A aortic dissection using the left internal mammary artery by Dr. Magagna from Vicenza, Italy.
Good morning. Thank you for this opportunity. And I work in Vicenza. My name is Paolo Magagna. No disclosure. The management of the left subclavian artery during a frozen left trunk with the branching of supra-aortic vessel is controversial and sometimes challenging, especially during emergency procedures. Although there are many potential complications for the subclavian artery occlusion, like stroke, spinal cord ischemia, or upper lung ischemia, and if left subclavian artery coverage is necessary during FET, and it is debated whether it should be revascularized or not. Even if recent guidelines issued by the Society of Vascular Surgery suggest the left subclavian artery vascularization whenever possible, evidence-based data supporting this recommendation are still missing. The gold standard for the LSA revascularization remain direct revascularization end-to-end anastomosis, carotid subclavian artery bypass, aorta subclavian axillary bypass. But there is the drawbacks, like complication, vocal cord paralysis, bleeding, or brachial plexus injury. And these procedures are not always feasible. Unfavorable anatomy, classification, anomalous region, and technically demanding, especially for an experienced surgeon and during emergency surgery. And so we hereby describe a novel technique to revascularize the left subclavian artery during FET with aortic arch debranching. In particular, LIMA resting as a conventional CABG, LIMA distal anastomosis to the ascending aorta vascular prosthesis with the consequent blood backflow, LIMA to left subclavian artery, and closure of the LSA director, or in second time with the plug with the percutaneous procedures. Case presentation: a 64-year-old man with a history of hypertension and smoking was admitted to my hospital with the diagnosis dissection aortic acute type A, and underwent emergency surgery. Surgical technique: right axillary artery cannulation, moderate hypothermia 26 centigrade, brain protection with selective integrated cerebral perfusion, aortic valve replacement with stainless, and ascending aorta and aortic arch replacement with the bypass of the illuminating artery and the left common carotid artery. I used the vascular prosthesis multi-branching LPA. And for the left trunk, I used the Vita Open Plus with the coverage of the left subclavian artery. In this case, not possible for me the revascularization of the left subclavian artery for unfavorable anatomy. The origin is very deep, was very deep. And so, during rewarming, LIMA harvesting, in-situ LIMA to ascending aorta vascular prosthesis anastomosis with the prolene 7O, a closure of the origin of the subclavian artery with direct suture. The operative data is very good. The flow on the LIMA, 150 milliliters per minute. The post-operative course, the patient was uneventful, and data arterial pressure left arm versus right arm very low, 20 millimeters for mercury. Follow-up: this is angiocentric scan 1 year after the procedures. You can see the patency of the LIMA and the left subclavian artery and the vertebral artery. Vascular echo-color Doppler, good flow, but slightly lower flow velocity in the left subclavian artery versus right subclavian artery. Transcranial Doppler TCD evidence the integrated flow in the left vertebral artery. In conclusion, the left subclavian artery vascularization with the LIMA to ascending aorta anastomosis in order to achieve blood backflow during FET with arch debranching is technically feasible. At 1 year's follow-up, angiocentric scan, vascular echo Doppler, and TCD show good patency of the bypass with excellent flow in the left subclavian artery and antegrade flow in the left vertebral artery. This technique seems easy and reproducible, even if future data are needed to assess the safety and efficacy. This is the patient. This is the patient that would clearly show both strength in his left arm, winning arm resting with me. Thank you for your attention.